Good afternoon, ladies and gentlemen. Thank you very much, Seema. You and me seem to be linked together always in these conferences. Hello, Bani, meeting you after a long time. Gautam, thank you very much for giving me this opportunity and also giving me a topic like endometriosis, which is my favorite after PCOS. So, thank you very much. My topic is endometriosis and infertility. My lecture overview is going to be after a short introduction. I'll introduce you to endometriosis fertility index and the chances of predicting long-term pregnancy in women. Who needs surgery for endometriosis? Who needs IVF for endometriosis? And do women with endometriosis have poorer IVF outcome? So endometriosis is an ancient disorder, and one of the best known examples is Queen Victoria in the 17th or 16th century, and she was known for her menstrual blues, but she also knew how to treat herself. She would treat herself with marijuana and by getting pregnant every year so that she would keep her endometriosis in bay. Now, endometriosis is a challenge, we all agree, but mostly it is a very, very damaging disease. It's like a danger within, the poor woman doesn't know. And it affects all the mechanisms of fertility. We know many, I don't want to go into detail, the altered tubo-ovarian dysfunction, the peritoneal dysfunction, the abnormal peritoneal environment with minimal mild endometriosis also, and now the fact that we are learning about progesterone resistance and abnormal gene expression profile. Unfortunately, endometriosis and infertility, they throw up many complex questions. So we have to deal patient one-to-one, and we may not have any clear-cut answers. So we may not have any recommendations to give forward, which will apply for all patients, So for the ease of diagnosis and management of patients, it's a good idea to make our patients into any one of these categories: stage 1 and 2, which is minimal mild, stage 3 and 4 endometriosis, those with endometriomas and those without endometriomas, women with deep infiltrating endometriosis, and then women who have recurrent endometriomas or who have undergone previous surgeries. And today I'll be speaking most of my recommendations from the 2021 final draft of ESHRE guidelines. We know that ESHRE guidelines for endometriosis of 2014 exist, but now, although this has not been published yet, it is out there in the net for the public to review and to give their opinion. So I have taken all the guidelines from here. So the first thing I wanted to talk to you about was endometriosis fertility index. This was popularized by Adamson in 2010. The aim was to develop clinical tool that predicts pregnancy rates in patients with surgically documented endometriosis who attempt non-IVF conception. So this was for non-IVF women. This is an excellent scoring system which all of us should learn and try to do during surgery. It takes into account the American Fertility Society grading, which is little complicated. Along with it, it takes into account least function score of bilateral tubes, the fimbria, the ovaries, the peritoneum, and then combines it with many historical factors like age, patient history, whether prior pregnancy, how long she has been married, etc. And then they come out with a score. This score gives us a very good prognostication for pregnancy for patients, which we can talk to our patients about. For example, if a patient has a high score like 8, 9 or 10, then her chances of getting pregnant spontaneously without any treatment in the next 3 years is about 80%. But if her score is as much as 0 to 3, her chances of getting pregnant in the next 2 or 3 years is barely 5%. So this is an excellent tool which everybody should learn, understand, and use it for patient counseling. It is available, of course, you can go through and try and do that. So endometriosis associated infertility and fertility enhancing surgeries go hand in hand. We all know that. Surgery is a part of managing endometriosis because we need that for diagnosis also. But always you will note that reproductive surgeons and reproductive ART specialists are always debating. No surgery, yes surgery. IVF people don't want to do surgery. Reproductive surgeons, they want to do surgery even for deep infiltrating endometriosis. So let us see if we can get some kind of a consensus as to who needs surgery in endometriosis. So stage 1 and stage 2 endometriosis are the minimal mild endometriosis. As a person, as a doctor, a gynecologist who is seeing patients in her OPD, how am I supposed to even diagnose this? It's not possible. Yes, a very good ultrasound, if you do your own ultrasound, a good transvaginal ultrasound will pick up very subtle points, which is very important. People who do ultrasound they can pick up small nodules, they can pick up tenderness in the pouch of Douglas, they can pick up endometriotic lesions in the uterus sacrals, they can pick up rectovaginal endometriosis. So that will help. But still, to diagnose this, we will have to do a diagnostic laparoscopy. And if we do a diagnostic laparoscopy, are we supposed to do a complete clearance, which is recommended, and how many of us actually are able to do it and do it? Because you see, in simple cases like this, wherein by chance you note a little bit of red active lesions in the uterus sacral, in the POD, which has adherent a little bit of rectum, or a little blue black lesion here, or a few flimsy adhesions, rest everything is okay in the pelvis externally. So you are actually supposed to do a complete clearance. You may use, of course, bipolar coagulation and ablation of the lesions, all visible endometriotic lesion, but ideal is to do a complete clearance either using a bipolar cutting device or a laser device. But how many of us are actually doing it? How many of us are doing it without creating any complications? Because I myself have seen, a ureteric fistula as a result of burning various lesions in the pelvis using a bipolar. And so the point is, if recommendation is to do complete clearance. To do a complete clearance, it will be a 1 hour, 2 hours, 1.5 hour surgery. The patient has to be counseled and patient has to pay accordingly. So it's something which practically doesn't happen. The least we can do is a detailed pelvic assessment, create an endometriosis fertility score, restore anatomy tubo-ovarian relationship as far as possible. And of course, the point is, if we are planning a natural pregnancy for this patient, that means if after the procedure, diagnostic laparoscopy, you are letting her for next a year or so to try spontaneous pregnancy, then as far as possible we should do a clearance surgery, provided the surgeon has the skills and the time and effort to be able to do that. Now, a little more serious and advanced disease like stage 3 and stage 4 is a little more difficult. इसको कैसे run करेंगे? हाँ, आए. So see, the point is that I'll just give some example of some cases to explain my point here. Let me put it on only. So see, for example, a patient who's 27, married life is 2 years, she has come to you for pre-pregnancy counseling. Her primary complaint is primary dysmenorrhea. She's never come for you for infertility. By chance on investigation, you find this kind of a scene. There is the uterus is normal and there is a small endometrioma, maybe about 2 centimeters or so. See, majority of us will have a debate whether we should do a laparoscopy or not. Many laparoscopic surgeons would definitely want to go in and do a surgery and at least do a pelvic assessment. But many ART specialists would debate against doing a laparoscopy for this kind of a patient. But when you do a laparoscopy, you see that the uterus, the ovary, of course, is densely adherent. The tubo-ovarian relationship is totally spoiled. And so this patient is not going to get pregnant even though her tubes are open completely on diagnostic laparoscopy. In her, I have not done a HSG. I have gone in straight for HSG, straight for laparoscopy. So the point I am making is that many of us will not agree on doing, but the right time, if the patient is young and if she has a good ovarian reserve, we should be doing. Another patient, see, she is 28, primary infertility of 3 years. First line investigations are all normal. HSG is normal, male factor is normal. When she comes to you, you do a scan and she has a small endometrioma. Would you take her up for operating laparoscopy or not? Again, there would be a debate whether we should be doing or we should not be doing. But when you see that, since she's married life is only 3 years, many would argue for a IUI. But when you do a laparoscopy, you see, is she going to get pregnant with IUI? No way, because the tubo-ovarian relationship is so spoiled and the tubal adhesion, the pelvic adhesions are so strong that she's not going to get pregnant. And if you do a good TVS, you will realize that both the ovaries are stuck to each other here. So there has to be a pelvic factor and a tubo-ovarian factor for which you have to take her up for a surgery and do a good clearance as far as possible, and then plan a COH IUI, or else decide on doing a Now, large endometriomas and bilateral endometriomas are a totally different ball game because they are much more difficult to do. The skill of the surgeon is very important. The first surgery is always the make or the break surgeon. So it's the patient's luck where she falls, with which surgeon she falls for a surgery of this nature. So, of course, many other aspects come in, and we are not going to discuss that because that will go more in the lines of surgical conference. So, the point I'm trying to make here is that there are definitely cases where you will need surgery, and you have to choose them properly. Now, another patient, very interesting, you see, she's 30 years old, primary infertility of 5 years. After 5 years, she has come to you. Baseline investigations were all normal, male factor, HSG normal, patent tubes, everything. AMH is 1.87 nanograms. But when you do a scan, you pick up subtle findings of endometriosis. The uterine cavity is typically beaked, the question mark sign. The pelvis, the pouch of Douglas is totally obliterated. The ovarian outline is not very clear. And so you have to take her up at least for diagnosis. And then when you do a diagnosis, you see how is IUI going to help this patient. So you will have to either take her up for a IVF, or you have to do a complete, adhesiolysis, tubo-ovarian clearance, maintaining, proper before you are able to do. So, if you are trying for natural pregnancy, yes, the patient needs complete clearance. But the main thing is that patient has to be young, good ovarian reserve has to be there when we take her up for surgery. And after surgery, who needs assisted reproductive technique? That has to be based on endometriosis fertility index. That will tell us who you will take up for IUI and who you will take up for IVF. So whenever you see a patient with grade 3, grade 4 disease, with or without endometrioma, the question will come whether to operate or not to operate. The question you should ask yourself is she a candidate for assisted reproduction? Is she a candidate for IVF based on her age and many other things that you all are aware of? If she is for IVF, then surgery should be the last option that you will think of, and IVF you will take up in all cases of endometriosis who have low ovarian reserve. In fact, you will take up patients for IVF in case with an emergency IVF if they are of advanced age and very low ovarian reserve, even if they are young and they are married for a very short time. So these are various questions. I think I'll have to skip because of the time. Surgical therapies prior to assisted reproductive technology. So just now I mentioned that if you are planning a young patient for natural pregnancy, after the surgery for endometriosis of stage 1, grade 2, or even an endometrioma surgery, you will operate. Surgery will give her a better choice. So is it possible that before planning IUI or IVF, operating on on these kind of patients will give you a better result? But evidence tells us that there should not be any surgery planned before assisted reproductive technology. So any patient who is a candidate for IUI or who is a candidate for IVF, we should not be taking them up for surgery. Having said that, I will show you another patient. She is 32. She is married for 6 years. Her AMH is 1.69. HSG patent tubes, male factor normal. Transvaginal shows us like this. Multiple small endometriomas both sides. So certainly she is a candidate for IVF, you have realized. But when you see multiple 5, 6 small follicles, again, everybody in the audience may not agree with me. You might still want to go in for a IVF and do egg collection. But I thought with multiple such small endometriomas of 0.5 centimeters and 1 centimeter on both sides of the both ovaries, it will probably really create issues while egg collection. So I did take her up for surgery. She had extensive endometriosis. I tried my best as much as possible to do a clean surgery. No energy source was used. I gave pitracin and kind of finished the surgery after that. So there are cases where you will have to operate on endometriomas and endometriosis before ART. Some of the examples are if there is a rapid growth of endometrioma, sonographic suspicion of malignancy, because we know that recurrent endometriomas and long-standing endometriosis can harbor cancer, severe incapacitating pain, risk of rupture of an endometrioma, presence of an hydrosalpinx, If you see that, you'll have to take her up for a laparoscopy to clear. Whether you clear your endometrioma or not is another matter. Very, very large endometrioma and interference with OPU. In these cases, you might even have to take them up for surgery before you plan your IVF. And repeat surgery, of course, we should almost never be doing. So the last part of my talk, which I had mentioned, do women with endometriosis have poorer IVF outcome compared to others? And before that, let me just give you one small point which I have forgotten in my earlier slides. So the new draft, if you all will remember the ESHRE guidelines of 2014, which was the best document to understand about and to take guidance for managing endometriosis patients, they had various cutoff points. 3 centimeter endometrioma you will operate, 4 centimeter endometrioma you will operate, less than 3 centimeter you will not operate, and there would always be debate amongst doctors in meetings like this. But the new guidelines have not spoken about the size at all. Whether 3 centimeter or 4 centimeter, they just talk about choosing the patient correctly based on their age and their profile and the endometriosis fertility index to base which patient to operate on. Now, this is another question we have. We know that our endometriosis women have their best chances of getting pregnant with IVF. But does IVF outcome get poor because of endometriosis? Whether it is the oocyte, the embryo, or the endometrium. So to give you the latest data on this, this was a very recent publication and an excellent SART publication. They showed a total of some 3 lakh 3.5 lakh autologous fresh and frozen assisted reproductive technology cycles ranging for about 12 years. And they showed, almost my last slides, they showed that endometriosis is associated with lower oocyte yield, lower implantation rate, and lower pregnancy rates after IVF. However, the association of endometriosis and IVF outcomes is confounded by other fertility diagnoses. So that is important. So the point is that all these years we used to think that number of eggs are less, egg quality is bad, fertilization rate is less, embryo formation is less, embryo quality is less, implantation is less. But apparently the most important factors which are there, the evidence which has shown us is that the oocyte yield is low, which is understandable in endometriosis, and the implantation rate is the one which is most impacted with endometriosis and probably not the other factors. So, although the IVF patients' best chances, the endometriosis patients' best chances are IVF, but still it is impacted by certain implantation which we need to understand. And another 2021 publication of 6,000 mature oocyte showed does not have a negative impact on oocyte morphology. Another 2021 publication showed that there is no compromise of embryo quality. So in endometriosis, we have to worry about the implantation rate. The other things, if it is done at the right time and the right way, then we have no issues with that. Since I have finished my time, I think I'll just cross because these are just the recommendations and I'm sure you all will be able to read that. This is the last slide. This is one of the very good algorithms to manage your infertility patient. So during infertility workup, if you find any suspicion or diagnosis of endometriosis, immediately do the measurement of ovarian reserve. Ovarian reserve, if it is drastically reduced, go in for emergency IVF. If not, go in and other tests that we usually do, which is seminal fluid and assessment of fallopian tubes. If in between you feel that natural pregnancy should not be tried for her, supposing male factor or some mild tubal factor, go in for IVF. If everything appears to be all right, go in for surgery and allow her 6 to 18 months of spontaneous pregnancy, and after that you could go over for IVF. And at any time if you feel that it's not working, then she has to go in for IVF. And if you plan for IVF, do not plan any surgery before ART. You might even do an egg collection, freeze, and then plan your surgery that you want to have. Thank you very much.